Thank you very much, Beth. Good morning, everybody, and thanks for coming in. I'll be talking about the mechanical circulatory devices in the Cath lab, and I'll give you a little brief overview of some of these devices. And at the end of my talk, my colleague Pablo Enriquez will come on the stage and give you guys a case presentation. I have no disclosures. All right, so why do we need to use these devices? And studies have shown that there's a high potential of heart muscle recovery and gain in ejection fraction if we use support early in the event of myocardial infarction. And there's a very high potential if we don't use these devices that we can lose the ejection fraction and some heart muscle. So what are the patient populations and ideal goals for these cardiac support devices? So for the population, the patients going under high-risk PCIs and acute myocardial infarction, also the patient who have weakened heart and cardiogenic shock. Now, the ideal goals of these cardiac support is they should be safe and simple to use. They should provide systemic hemodynamic support throughout the body. They should protect the myocardium from further injury. Now let's look at the history of the cardiac support. In 50s and 60s came the ECMO, which is still very popular in OR settings. In 70s came the balloon pump. In 80s was the cardio bypass system. 90s we had hemopump. Then 2000 we had Tandem heart. And the most recent devices are Impella and CardioHelp. So let's look at a few differences between these devices. So the Tandem heart pumps for the heart. It's usually used in the patients who are bridged to transplant. It's very neutral to coronary flow. It provides up to 5 liters of support if inserted percutaneously and about 8 liters of support if implanted surgically. Next is IABP or intra-aortic balloon pump. It's not a pump. It increases coronary flow. It needs some sort of muscle strength to work properly. It's very timing dependent, and it provides only up to 1.5 liters of support. The next device is Impella. It pumps with the heart. It relaxes the heart muscle. It provides 2.5 liters of support percutaneously and about 5 liters of support if implanted surgically. The next device is a portable heart-lung support system, also known as portable ECMO or CardioHelp. It's extracorporeal membrane oxygenation system. It provides full respiratory support. It actually completely bypasses the heart. It provides up to 7 liters of cardiac support. It has an ability to induce mild hypothermia, and it's very, very portable. Now, how to choose what to use? So in Mount Sinai, we have an algorithm in which we look at patients' EF versus lesion complexity for the patients who are coming in for high-risk PCIs. So the patient who have EF of 35% or more, for simple PCI, we don't need any support. But for complex PCI, we can think about intra-aortic balloon pump. For patients with a moderately reduced EF, for simple PCI, we can think about intra-aortic balloon pump. For complex PCI, we can think about Impella, Tandem heart, or CardioHelp. And patients with severely reduced EF, simple or complex PCI, we can think about Impella, CardioHelp, or Tandem heart. Now let's look at some of these devices in a bit more detail. So the first one is Tandem heart. On the left side, you can see the computerized escort controller. In the middle, you have the centrifugal pump. And then 2 cannulas. One is the arterial cannula, which is a straight tip cannula, and the venous cannula, which is a curved tip. So it's a 2 catheter-based system. So arterial cannula sits in the femoral artery, while the venous cannula sits across the atrial septum. It pulls the blood from the left atrium and returns through arterial catheter into the system. It reduces the LV preload, workload, and oxygen demand of the body. It also increases cardiac output and mean arterial pressure. However, there's a risk of persistent ASD or atrial septal defect if left in the body for a long period of time. Now, the contraindications are right atrial or left atrial thrombus and peripheral vascular disease, since these are large bore catheters. Next, and the most famous device is intra-aortic balloon pump. It's made by several different companies. On the left side, you can see it's the pump. On the right side is the catheter system. It's a smaller arterial puncture as compared to the competition. It's only 7.5 French. It sits in the descending aorta, right above the renal arteries and below the subclavian artery. It inflates in the diastole. It decreases preload, afterload, and the cardiac work. It increases coronary perfusion and oxygen supply and cardiac output. The big benefit of this device is you do not need fluoroscopy, and it can be inserted bedside. Now, the contraindications are patients who have aortic aneurysm and patients who are presenting with aortic regurgitation. You can actually do more harm than good if you insert these devices in patients with AI. And last but not least, the peripheral vascular disease. The next is the Impella. It's a platform technology. The most commonly known Impella to the Cath lab are Impella 2.5 or Impella CP, inserted percutaneously. The next one is Impella 5.0 that requires a subclavian cut down. Impella LD requires a direct aortic approach. And the most recent catheter is Impella RP for right ventricle support. Now, I'll talk about the most common ones that we use in the Cath lab, Impella 2.5 and Impella CP. So these are catheter-based systems. They sit in the left ventricle. They pull the blood from the left ventricle into the ascending aorta, thus follows the natural blood flow of the heart. It reduces the left ventricle end diastolic pressure and end diastolic volume, also reduces the oxygen demand of the body. It increases the cardiac output and mean arterial pressure. So the contraindications are the left ventricle thrombus. Patient who have mechanical aortic valve, you definitely don't want to put these devices because you can actually damage the valve. Patient presenting with severe aortic stenosis and peripheral vascular disease. Next, I'll show you a little video animation about how this device is inserted in the body. So you take the peripheral femoral approach. The device goes on an 018 wire that is placed in the left ventricle through a pigtail catheter. Once the catheter is in the place, you can remove that 018 wire and you can start the pump. And the inlet area sucks the blood and in the LV, and it takes it out to the aorta, and it perfuses the coronary arteries and the other vital organs of the body. Next, I would like to call on stage Pablo Enriquez to come on the stage and give us a little case presentation. Thank you for listening.